Assalamu alaikum warahmatullahi wabarakatuh. This is Dr. Ala, consultant emergency physician in Saudi Arabia. Today, our topics will be a diabetic foot anemia. Diabetic foot is very important, very common. Many people worry about if they have diabetes for 20 years or more. They are worried. Okay, my foot I lose my foot, I will lose my health like this. But diabetic foot, we try inshallah in this lecture to make it simplified and to cover all hot points about it. At the beginning, I wanted to tell you what is the diabetic foot. What actually is the diabetic foot? To know the diabetic foot, you have to start from the root of the tree. Diabetic foot is come from diabetes. If the patients have a diabetes for long times, he have some complication. What is these complications he have? We have acute complication and the chronic complication. The acute complication, everyone in ER know it: hypoglycemia, DKA, hyperosmolar, whatever. This is not our topic. But the chronic complications, it happen if the patient have a diabetes for longer time, 5 years, 10 years, 12 years, 15 years, like this, uncontrolled. His sugar is high all the times. Plus, he's not drinking much water. And because of these sugars for longer times, in our blood vessel, it will destroy our blood vessels. What is a blood vessel destroys? Usually the diabetes destroys two main blood vessels: the macroangiopathy and the microangiopathy. Macroangiopathy usually affected the medium-sized arterioles, like a coronary, like popliteal, like mesentery, inferior mesenteric artery, like carotid. And if it affected this vessel, it will be affected by atherosclerosis. This is a pathology. Later on, this macroangiopathy can be showering, embolic, and thrombosed, cause stroke, cause MI, cause acute limb ischemia, whatever. This is not also our topic. But also, it will affect small blood vessels. It's called the microangiopathy. Microangiopathy, it happens if the sugar stay longer time, it will change to glycols materials. And these glycol materials will attack our endothelial systems and close it like a hyaline degenerations. It is blocked at the level of small, very small blood vessels. And because of this microangiopathy, the patients will have 5 main complications of the diabetes. Retinal, diabetic retinopathy, diabetic nephropathy, diabetic dermatopathy, diabetic neuropathy, and diabetic foot. Diabetic foot. Okay, diabetic foot is a disease. It's a disease due to the microangiopathy, but it happens only on the foot. It happens only on the foot. One question for you: if the patients have a diabetes, for example, for 20 years, shall he have all these chronic complications? No. Maybe have nothing. Maybe have retinal diabetic retinopathy only. Maybe have retinal nephropathy only. May have diabetic foot only. So diabetic foot is like a diabetic retinopathy, like diabetic neuropathy, need to be diagnosed as a disease. This is the first important information you have to know it about the diabetes. You have to diagnose. How I diagnose a diabetic foot? Let's go. This microangiopathy, this means that small blood vessels in your foot become very tight and there is no enough perfusion to your tissue. It will affect your nerves of your foot. But you have to stop. Not any nerve. Superficial nerve, pain, touch, tension, plus deep nerves. If you find only superficial nerve, pain with touch or temperature is lost, like the patient will come to you with burning sensations of the foot, pain, walk him hot, he feel hot, and this is called peripheral neuropathy. But in the diabetic foot, it's different. Also, the deep nerve is responsible for proprioceptive sensation, like sensation of our position, our move, sensation of the ground. All this become lost. Okay, to diagnose. How can I do like this? Just simply ask the patient to lie down, close his eye, catch the big toe, and fix the joint of the big toe, and try to move the big toe toward the face of the patient and toward yourself. If the patient can identify the position easily, this is not a diabetic. He cannot identify the direction. Also, you can use your fork, vibration fork, to check the vibrations. Okay. This is, if the patient has this, then we diagnose him as a diabetic foot. You have a diabetic foot. You have to tell him this is a diabetic foot. You have to be careful. You have to follow up with diabetic clinics, with diabetic foot specialists, to follow up this condition and give him the instructions. Right. What is the next question? If the patient have a diabetic foot, what is the problem? For example, if the one patient came to you in ER, and okay, you diagnose him as a diabetic foot, or diagnose from the clinicians as a diabetic foot, and he came to ER complaining of his foot, and you open his foot, expose his foot. What we are searching for? Actually, we are searching for 3 main problems. We have to make a list in your mind. Okay, 1, 2, 3. First list is ischemia. Second, bone fracture. Third, soft. I will keep this soft tissue for the last because it is the main issues now. Ischemia. What is the meaning of ischemia? You have to know that in diabetic foot, there is a small blood vessel is closed, so the total perfusion of the foot is decreased. I'll give you one example. This foot, مثلا, if you cut it and you take all the blood from it, it will be, for example, 100 ml. مثلا, this is just example, 100 ml of normal foot. In diabetic foot, no. Sometimes it have 80, sometimes it has 70, sometimes it has 60, sometimes it have 40. If the blood perfusion become low, what the foot will do? It will redistribute this. Okay, so check the active move like muscles. It will give her the blood and deprive the blood from the superficial, like redistribution of the blood inside itself. If the patient lost some skin, she will not give him blood to heal because she already wanted to keep all the blood in deep in the structure to protect the bone and the muscle. So ischemia can happen by 2 ways. What is the character of ischemia? 2 things: either present of dry gangrene or present of the ischemic ulcer. Ischemic ulcer usually in the tip of the toe. If you find this one, tip of the toe, ischemic ulcer, or if you find a dry gangrene, we have to think, okay, it is from a diabetic foot, normal progress, or it is from the proximal, because I told you diabetes can affect atherosclerosis, especially popliteal, and it can cause acute chronic critical limb ischemia, and it will affect. This is now emergency. So what I will do? Doppler or CT angio to discover it is severely, the vessels proximal is severely interrupted or not. If severely interrupted, need a vascular to bypass it and improve the perfusion. But if everything is okay proximal, then this is a normal progress. Normal progress of the diabetic foot. When we reach diabetic foot to critical, the amount of the blood will become very low to the skin, the patient ischemic changes will happen. The one finger, second finger, it will chronic, it will take times to be formed. So this is the first important. I open the foot, I check for ischemic lesions. And then when I found ischemic lesion, I have to answer, it came from proximal or it is a normal progression of the diabetes. What is the other problem? Fracture. Everyone knows that diabetes, the most important point in diagnosis of diabetic foot is lack of proprioception. Especially when the patients walk, he can hit the ground, and he can have a fracture, especially in the head of the talus. So the talus, when it get fractures, it will go to the thole, making a pressure point in the middle of the thole. And this is very big problems. But it happens acute and chronic, of course. The patients will come to you with unilateral foot swelling, and he's diabetic for 20 years. You examine him, it is diabetic foot. You have to suspect it about the acute shock, because if you suspect it, can be treatable early with orthopedic, put him in back slab, and send him for the orthopedics, to handle this fracture. But if it has become chronic, it will find deformity. especially the middle malleolus will go down and become swelling, and there is pressure point in the sole of the foot. Okay, that's why it's very important to identify. If the patient chronic Charcot, what will do? Nothing. Just send him to the diabetic foot specialist. He will make the only treatment is to wearing a suitable shoes to protect the foot from this new pressure ulcers. This is the second topic. I'm searching for a fracture. But what is the third problem? Soft tissue. This is the most important. Soft tissue, when you open them, you find soft tissue. Either the skin is breaked or the skin is intact. The skin is intact, maybe there is a cellulitis, regular cellulitis. Or the skin is break. How the skin is breaked? Many things: wound, burn without notice, and neuropathic pressure ulcer. Neuropathic pressure ulcer of diabetes is usually present in a pressure point, especially the middle aspect of the peak two and in the sole itself, the proximal part of the sole, the ankle itself, with pressure. But sometimes with pressure point can be created by what is a Charcot joint, Charcot fracture. Okay. But if you find these ulcers, you have to answer the questions. What is the problems of these ulcers? We have actually two problems. One problem is lack of heat, because I told you that the diabetes foot will keep all the blood for vital organ and deprive meat, skin, and other tissues from it. So healing is very difficult, and this is not a big deal. But the problem, if there is any infection, pass through this door or not. Because if there is any infection, pass through the door, we'll have three types of situation. First one, life-threatening condition. Second one, limb-threatening condition. Third one, non-life, non-limb-threatening condition. Life-threatening condition, we are not looking at the diabetic foot. We are looking at the faith of the patient. This infection will reach to the blood, cause septic focus. The patient will have disorientation, fever high, white blood cells high, looks sick, blood pressure is low. We are looking at it. Then we expose the foot, find this. This is life-threatening condition. If the patient has life-threatening condition, must be admitted, culture, antibiotic, and the best management. Okay, this limb become threatening of the life. It's better to be removed from your body. Okay. Right. What about the limb threatening? Okay, the infections will come to destroy. I am coming just to destroy your limb. I will not destroy your life. This is called limb. How come it happens? By two things. Either to form it acute osteomyelitis or to form wet gangrene. Osteomyelitis, how to suspect this one? Patient generally looks healthy, well, nothing, now every lapse is normal. Exposed the wound, you find like either these ulcers become very deep, reach to the bone, or become very big, or SR is high. SR is very important in this situation because if it is more than 40, increase the chance of osteomyelitis 12-fold. And if it is increased more than 70, this means nearly the diagnosis is acute osteomyelitis. X-ray also shows interrupted on the periosteum. Gas is presented around the foot. If touch, you feel gases, or cryptis. All these things, it's highly suspected this infection caused limb-threatening condition and reach to the bone. What about the weak gangrene? Weak gangrene, infections will come. Sometimes some infection produce gas, like gas gangrene. Some polymicrobial infection, maybe MRSA is very high, but all of them is joined in one thing. The limb will be swelling, looks a little bit dark, but dark like a gangrene, but without a line of demarcation. You can find some gases inside the foot. This is called weak gangrene. The high chance to form a life-threatening condition. So the infections, we go inside. Which infection can threaten the limb? If the infection which reach to the bone, acute osteomyelitis, or to cause necrotic tissues and wet gangrene. If the patient high like this, his limb become a threatening now. Must be removed, because if you keep it, the infection will stay for a long time and it will go to maybe the chance to go to the systemic circulation and cause life-threatening. But if the patient have no life-threatening, no limb-threatening infections, what we will do? Just cleaning the wound.